Hello, good morning, everyone. We're just gonna give about another minute or two for others to join us. So just give us another minute or two and we'll get started. Thank you. Hello, good morning, everyone. Thank you for joining the Georgia Clinical Quality Measure System, Georgia CQMS webinar. My name is Christy Washington, and I'm the Pop Health Research Data Analyst here at the Department of Community Health. I will be your moderator for today's webinar. This is the last part in the Take 5, How eCQMs Improve Patient Care and Outcomes webinar series. Jeff Jacobs with DXC Technology will present an overview of the project. We will deep dive into 3 CQM measures for behavioral health with Chris Huckabee from Health Tech Solutions. And a clinical perspective will be given by Dr. Dan Roach, also with Health Tech Solutions. Winner Law with DXC will provide us with a presentation of the system. And today's webinar will show the system capabilities and functionalities, including how to enter clinical measures data and generating provider performance comparison reports. At this time, I'd like to remind everyone that this webinar is being recorded, and the presentation as well as the recording will be available on the DCH website. Secondly, this presentation is also available for you to download in the handout section. If you're unable to download that presentation, please send us an email at hit.info@dch.ga.gov, and we'll be happy to send you out a copy. Again, that is hit.info@dch.ga.gov. Please hold all your questions until the question and answer session. At that time, please raise your hand and we'll unmute your line so you can ask your question, or tap it in the chat or questions pane and we'll read your questions out loud. And at the end of this webinar, there will be a brief survey, and please just take a moment to complete that survey. And at this time, I will turn the webinar over to Jeff. Thank you.
Hey, good morning. Thanks everybody for your time this morning. Again, this is Jeff Jacobs with DXC Technology. We really appreciate your participation. So we'll jump forward, and we've got a couple slides here up front that share the department's mission. Give you a quick second to take a look at that. And then next up is the purpose, obviously a shared purpose that we have with our provider community to improve access and quality, to strengthen the communities that we serve. So as Christy mentioned, we've got a full agenda, a lot of good information to share. Ultimately, I want to upfront give you the context that we're hoping to share this information that you might consider participating and being included in our project. It is a volunteer project, and a project that we are we recognize that you've got a lot on your plate, so we try to do everything we can to make any time that you have to spend very efficient and minimal. So we want to give you a lot of good information today, and again, appreciate your time attending. So let's jump right in. The project that we're sharing about today, we refer to as the Georgia CQMS Clinical Quality Measure System Project. And with this project, we have implemented and are operationalizing an effective way to accept CQM information from providers across multiple channels. Really, when we say multiple channels, we're really just saying we accept input through an EDI transaction. QRDA3 is the transaction that's involved. We receive input from paper, or you can manually enter the information online, and we'll show you a little bit about how that works. The goal is to assess trends across various benchmarks, right? So we've got member and disease categories, provider geographies, or subsets of provider types. Our goal is a phased approach, and the whole reason we're doing this is really, this is where the industry is going, right? The industry is going to value-based assessments, to outcomes. Are we investing in the right places? Are we investing in ways that create the results that we hope to create as a program, right? And so ultimately, we view CQMs as one input in that process, and we want to gain insights and lessons learned from folks participating in the project. So during my portion of the presentation, we're going to do a couple of polling questions. You've got a polling feature where you can answer yes or no to these questions, not terribly complicated. Is your practice currently looking for an effective way to capture clinical quality measurements? And that's just a quick yes or no. If you'll take a second and help us, maybe give us a sense of whether your practice is looking for an effective way to capture clinical quality measures. And in some cases, you may already be capturing clinical quality measures. So we'll talk about that in just a minute. Thank you, everyone, for responding to that poll. We've got a few more questions we'll ask you. So project benefits, right? At the end of the day, our goal, our mission is to improve health outcomes for Medicaid members. We're very much aligning with programs that if you participate with Medicare, you're seeing on the CMS side, where they are collecting very similar inputs, and we want to make assessments about how we're doing. The goal here is to provide input to the department as they make decisions about programs moving forward. The goal is a consistent platform built on standards, rules-driven, to provide consistent, meaningful input, right? Obviously, we've got three goals of our healthcare system in mind: better care, smarter spending, healthier people. Okay, so let's, question number 2. We'll keep it interactive. Would comparing provider data to state average data benefit your practice? Would it be helpful to be able to make assessments about how we're doing against a state average? Again, we'll give you a second to give us some yes and no's there. Maybe compare those against certain disease states, maybe compare that against certain geographies or provider types. Okay, so thank you again for your input. That's helpful for us to understand your perspective. So the project offers the following services to providers, right? We want to train folks on how to use the system capabilities. We have the ability to accept inputs through an EDI file. That's the QRDA3. That's kind of an intimidating QRDA Cat3, but it's really just the electronic file. You're used to hearing probably 837s or 820s or 834s. Those are really on the claim side of the world, but QRDA Cat3 is just the EDI file or the manual entry of CQMs. We display the data on dashboards. We'll show you a little bit of what that looks like. And some folks early on, this is one of our lesson learns, one of the adjustments we made. Sometimes entering the data can be a little bit time consuming when provider offices have a number of participants. So we've offered to enter the data directly for participants. So it can be that you simply give us a printout out of your EHR environment and send it to us. We don't really have or require a standard format for that. We're looking to be flexible and take advantage of where you're able to share information and sort of meet you in that process, right? And so we try to be very efficient in our project activities. And really, let me just make sure we don't lose sight of what that really involves. The project from a provider standpoint is really about just sharing those CQM measures out of your EHR system. Because we're interested in QRDA3 measures, that means we're looking for aggregate level data. There's no PHI involved. We're not looking for any member specific information. It really is the CQM that you're reporting, a numerator, a denominator, and then exceptions and exclusions where applicable, right? And so it's just those data values. So very straightforward. We do want to make sure that we have participation from the clinical side of the house when we undertake a project like this. So we have a clinical advisory board, or CAB, as we refer to it in short. The goal is to get that clinical perspective, to get advice, recommendations. We have a number of participants. We have a diversity of disciplines and participation. We're going to hear from one of our CAB members on today's call, Dr. Dan Roach. And the CAB is very important, helping guide us as we make our way through the project. Okay, again, one additional question. Would you utilize trend analysis or reporting to monitor population health? So obviously we're making that available. Would that be of use to you? Would you utilize trend analysis or reporting to monitor population health data? Thanks again for your input. And so let me pause real quick. All right, so let's tell you about where we are now. So our current project status. So we've got 84 individual participants from various provider organizations. These provider organizations represent different specialties. We currently have 7 CQMs in the system. One of them was removed from CMS as a standard reporting. It was asthma-based. Everybody was compliant. It wasn't a very interesting measure, so it's been voted off the island, right? And so that brought us down to 6. And one thing that's slightly different with our program is we're looking to collect the data quarterly. So we want to get a little bit more timely input. I believe the CMS program receives it annually. And so let's see what those measures are specifically that we currently collect. You can see there's our asthma measure that's sort of been voted off the island. But we've got some behavioral health screening. We've got BMI. We've got breast cancer screening, high blood pressure, chlamydia screening for ages 16 to 24. And then we are adding additional measures. So we've, again, taken input from project participants, from our clinical advisory board as well. And these are measures that we are adding to the project. You can see here a little bit more emphasis on some of the pediatric side of the house with the number of children measures added. Again, some antidepressant medication treatment on the behavioral health side, congestive health, heart failure. So we're going to talk a little bit about, next up in our discussion, about some of the CQMs specifically and share a little bit of a perspective from one of our team members. Before we do that, we've got our last poll, our last internet. So folks who are loving the polls, this is the last poll. You can join us again next month and take the polls all over again if you're interested. But so has your provider, has your practice spoken to your EHR vendor about QRDA files for clinical quality measures? Have you had any discussion about the ability to report clinical quality measures with your EHR vendor? That's a pretty common response on this one. And so that might be one of the things that we'd like to do if you were so inclined to participate in the project, and is just sort of get their perspective on the ability to generate those. That's ultimately a requirement that you'll see going forward when reporting these kind of measures. Okay, I appreciate your time and sharing a little bit about the basics of the project. Let me turn it over to Chris Huckabee, who's going to share a little bit about some of our specific measures that we're collecting. Chris?
Thanks, Jeff. This is Chris Huckabee, and the first measure that we are going to take a deep dive into is CMS 128, which is the antidepressant medication management. Next slide, please. Can you hear me? Yes. Okay, good. For the measure description, the percentage of patients 18 years of age and older who were treated with an antidepressant medication, had a diagnosis of major depression, and who remained on an antidepressant medication treatment. There are two rates that CMS wants reported. The first one is the percentage of those patients who were on an antidepressant for at least 12 weeks. And the second rate is the percentage of patients who were on an antidepressant for at least 6 months. For the denominator, or the initial patient population, we're looking for those patients 18 years of age and older with a visit during the measurement period who were dispensed antidepressant medications in the time within 9 months prior to the measurement period through the first 3 months of the measurement period. They also had a diagnosis of major depression 60 days prior to or 60 days after the dispensing event. Next slide. For the numerator, we're specifically looking for those patients who had received an antidepressant medication for at least 12 weeks of continuous treatment during the 114-day period following the index prescription start date. For the second rate, it's those who are receiving antidepressant medications for at least 6 months of continuous treatment during the 231-day period following the index prescription date. So who is excluded from this measure? Those patients who were actively on an antidepressant medication in the 105 days prior to the index prescription start date, otherwise known as that index episode start date, when major depression was diagnosed. This is the earliest prescription dispensing event for an antidepressant medication during the period of 270 days prior to the start date of the measurement period through the 90 days after the start of the measurement period. And all these numbers can be quite confusing, but the thing to remember is the measurement time frame is dependent upon that index prescription start date. For example, the prescription start date for this episode of major depression could be within the 9 months before the selected measurement period through the first 3 months of the measurement period. The diagnosis of major depression must occur either 60 days prior to or 60 days after the prescription start date. The exclusion should be taken for those patients who were on antidepressant medication 105 days prior to the prescription start date. For example, if the patient was already on an antidepressant prior to the prescription start date for this episode for major depression, then they must be excluded. There are no denominator exceptions for this measure, and in order to identify new treatment episodes for major depression, there must be a 90-day negative medication history. So what that means is for this period of time in which the patient is not taking any antidepressant medication. Therefore, the patient who are being treated with antidepressant medication within that 105 days prior, those will be excluded. Continuous treatment described in this measure allows for gaps in medication treatment up to the total of 30 days during that 12-week period, which is that first rate that's reported, or 51 days during the 6-month period for that second rate that's reported. Gaps can include either gaps used to change a medication or treatment gaps to refill the same medication. Cumulative medication duration is an individual's total number of medication days over a specific period of time. The period counts multiple medications with gaps in between. This again is a change in medication or the refill of the same medication, but does not count gaps where there was no medication dispensed. To calculate the cumulative medication duration, the number of medication days for each prescription needs to be determined. So to take the number of doses divided by the dose frequency per day, then adding the medication days for each prescription without counting the days between prescriptions. So to make this a little bit more clear, the original prescription for an antidepressant medication was, for example, 30 days with 2 refills each for 30 days. After a gap of 3 months, the medicine was prescribed again for 60 days with 1 refill for 60 days. So you would take the 30 times 3 plus the 60 times 2 equals 210 medication days over a 10-month period. So that would be how you would calculate the cumulative medication duration. Depression is estimated to affect nearly a quarter of adults over their lifetime. Symptoms of depression include appetite and sleep disturbances, anxiety, irritability, and decreased concentration. The American Psychiatric Association recommends use of antidepressant medication and behavioral therapies to include psychotherapy to treat depression. These medications have proven to be effective, especially for patients with more severe symptoms. Among those patients who initiate antidepressant treatment, 1 in 3 will discontinue treatment within 1 month before the effects can even be measured. And nearly 1 in 2 will discontinue treatment within 3 months. With these statistics, it is imperative that we as providers closely monitor those patients who have been identified to be suffering from depression. Next slide. So how will having aggregate data in the Georgia CQMS help me to improve care to my patients? So as a provider, when I log into the Georgia CQMS, the landing page will be this dashboard that you see before you. I can see fairly quickly that I'm at 45% for those patients who've been on the medication for 12 weeks and 21% for those patients who've been on medication for 6 months, as compared to the state average of 64 and 69. In other words, I have identified less of my patients that have a diagnosis of major depression and for whom I have initiated medication therapy and continued therapy for both numerators. So I have to ask myself if I'm happy with that number. I'm below the state average. Would I like that a higher percentage? This should prompt me as a provider to be thinking of ways to improve the health care to this patient population. Having this data readily available will help me to improve that care to this vulnerable patient population because I can see where and identify where there may be gaps in care and where I'm doing well with my patients. So on the next slide, I can also see how well I've been doing on this measure over the course of a year. The next slide is a trend graph that shows the trending over a period of time for 4 quarters for a given year. For this measure, which is 128A, and this is the first rate that's reported, I have data in here for the first 2 quarters. So I can see how I've trended so far for the first 2 quarters of 2019. Once this data is entered for the entire year, I can do a trend analysis and identify any gaps and interventions and how that has trended over the year. This gives me a snapshot view of the trending and can help further improve the care to my patients. So that was CMS 128. The next slide will take us to CMS 136, which is follow-up care for children prescribed ADHD medication. So this description is percentage of children 6 to 12 with newly dispensed a medication for ADHD who had appropriate follow-up care. Again, there's 2 rates reported. The first are the children who had 1 follow-up visit with a practitioner with prescribing authority during that 30-day initiation phase. And the second rate reported is those who remained on the ADHD medication for at least 210 days. And in addition to that first visit during the initiation phase, they had at least 2 additional follow-ups with their practitioner within 9 months after the initiation phase ended. Next slide. The denominator for this measure, they've separated it out in the 2 rates as well. So we've got the children 6 to 12 who were dispensed the ADHD medication during the intake period, which is different than the initiation phase, and who have had a visit during that measurement period. The second rate is those 6 to 12 years of age who were dispensed an ADHD medication during the intake period, who remained on the medication for at least 210 days out of the 300 days following the index prescription start date, and who had a visit during the measurement period. The 2 rates for the numerator are specifically looking for those patients who had at least 1 face-to-face visit with their practitioner with the prescribing authority within 30 days after the prescription start date. And the second rate is those patients who had at least 1 face-to-face visit with their practitioner during the initiation phase and at least 2 follow-up visits during the continuation and maintenance phase. Now, it's really interesting and cool that one of the two visits during that continuation and maintenance phase can be a telehealth visit from the practitioner. Next slide. So the denominator exclusions are again separated out by the two rates reported. There are three that are common to both rates, and then one that will be different. The three that are common are they're going to exclude the patients that had a diagnosis of narcolepsy at any point in their history or during the measurement period, those who were actively on ADHD medication in the 120 days prior to that prescription start date, and those patients whose hospice care overlapped the measurement period. For the first rate, the patient who had an acute inpatient stay with principal diagnosis of mental health or substance abuse during the 30 days after the prescription start date. And then for the second rate, it's those who had an inpatient stay during the 300 days after the prescription start date. So who will be excluded from this measure? I've already told you about that. Next slide. There are no exclusions or exceptions for this measure. A few definitions that I wanted to go over with you to kind of clarify the difference between some of the language in this measure. The intake period is the 5-month period starting 90 days prior to the start of the selected measurement period and ending 60 days after the start of the measurement period. That index prescription start date is the earliest prescription dispensing date for an ADHD medication, where the date is in the intake period and the ADHD med was not dispensed 120 days prior. The initiation phase is that first 30 days following the prescription start date, and the continuation and maintenance phase is the 31 to 300 days following the prescription start date. The cumulative medication duration is the same definition as that we saw in CMS 128, and the formula for calculating that duration is the same as the example that was given in 128. In a survey conducted in 2013, they found that about 10% of American children aged 3 to 17 have been diagnosed with ADHD. Now, we think this is only 10%, but that equates to somewhere between 5 and 6 million children. ADHD incurs substantial financial cost for medical care and work loss cost for patients and their families. The average direct cost annually per ADHD patient is a little over $1,500 a year. Medication treatment has been found to be effective for the management of ADHD, but this requires careful monitoring by the physician. The key to effective long-term management is continuity of care with a clinician who is experienced in treating ADHD. Care should be individualized for each patient, depending on the severity of the symptoms, whether they have other psychological illnesses, their response to the treatment, and the degree of impairment in home, school, work, and peer-related activities. Close monitoring is needed for this patient population, with frequent review and modification of the treatment plan as needed. And the improvement indicator for this measure is the higher the score indicates better quality of care. Next slide. So going back to that question of how having aggregate data in the Georgia CQMS can help improve care to the patient. Again, we're at the dashboard and can see fairly quickly that doing a little bit better on CMS 136A and B than the state average for my pediatric patient who have been diagnosed with ADHD. The second thing that this lets me see rather quickly is that I'm at 76 and 63% with the respective rates being reported, as opposed to the state average of 43 and 50. So what does this number tell me? Again, am I happy with this number? What else can I do to bring that second rate of 2 follow-up visits within 9 months closer to that first rate of 76%? Keeping this in mind that this patient group needs to be monitored closely, what steps can I take to increase follow-up compliance? So again, on the next slide, we can capture a snapshot of our trend analysis, in this case for the year 2017. We developed some interventions for the gap that was identified, and you can see throughout the 4 quarters that we trended upward. Next slide. So our final behavioral health CQM is CMS 177, Child and Adolescent Major Depressive Disorder, the Suicide Risk Assessment. This measure description, the percentage of patients visits for those patients aged 6 to 17 years with a diagnosis of major depressive disorder that had an assessment for suicide risk. The denominator, or the patient population, is all patient visits for those patients aged 6 through 17 with a diagnosis of major depressive disorder. Numerator specific are those patients with an assessment for suicide risk. Next slide. There are no exclusions or exceptions for this measure. The research has shown that patients with major depressive disorder are at high risk for suicide thoughts and for suicide completion. Suicide risk is a critical consideration in children and adolescents with major depressive disorder, and an important aspect of care that should be assessed at each visit and subsequently managed to minimize this risk. Research indicates that many individuals who die by suicide do make contact with their PCP or their behavioral health specialist beforehand. Approximately 15% of suicide victims aged 35 years and younger had seen their mental health provider within 1 month of the suicide completion, and approximately 23% had seen their primary care provider within 1 month of their suicide completion. The evaluation must include assessing for the presence of harm to self and others. This behavior exists along the continuum of passive thoughts of death to a clear developed plan, and then intent to carry out that plan. Depression is closely associated with suicide ideation and should be assessed at every visit. So a suicide risk assessment should be performed at every visit for those suffering from major depressive disorder during the measurement period. This is an episode of care measure with the level of analysis for this measure being every visit for this patient. Using a standardized tool or instrument to assess suicide risk, this will meet the numerator performance. And then again, the improvement indicator, the higher score indicates better quality of care. So on our next slide, we'll go back to that question and see our dashboard again. And we can see fairly quickly that I'm at 46% with this patient population. And I have to ask myself if I'm happy with a less than half of my pediatric patients with major depressive disorder are being assessed for suicide risk. I should be thinking about how can I ensure that these assessments are not forgotten, or maybe this is being done and it's not being charted. Either way, there's room for improved care. And again, on the next slide, we can see the trend. So as you can see, the system can give you targeted information that can help and be used to improve office processes, patient education, and target specific patient populations to improve outcomes. And my motto is, if we make a difference in one life, we've done our job. So this concludes the behavioral health review of the CQM. And with that, I will turn this back over to Jeff.
Okay, Chris, thanks so much. That's a lot of good detail. Really appreciate you taking us through that. And now, Dr. Roach. Dr. Roach, we think we've got you off mute. Can we test real quick? Are you there?
Yes, I'm here. Can you hear me?
Fantastic. So Dr. Roach is a member of our clinical advisory board that also works with Health Tech Solutions. Dr. Roach, we'll turn it over to you.
Okay, thank you so much. Well, I think, as has been said before, the whole idea behind this program is to really help you in the clinics identify, any gaps in performance, but more importantly, to find opportunities to improve and manage the quality of care. And this is really, really important for you as we move more from a fee-for-service, based system to a performance-based care model. And even though we may not be completely there yet, there's no time like the present to start practicing and getting into this mode of thinking. I just want to spend a couple of minutes talking about really what drives all of this. I think we've heard today some of the Institute of Healthcare Improvements, the triple aim of improving health of populations, lowering the overall cost of healthcare, and improving the patient care experience. But CMS has kind of taken that a step further, and they've developed, based on that, they call their quality strategy goals. And I just want to read their mission statement. It's to optimize health outcomes by leading clinical quality improvement and health system transformation. And that is a really loaded statement. And if you look at the 6 quality, strategy goals, there's a lot in there. There's a lot packed into 6 statements, and I'll just kind of go through them quickly. The first one is to make care safer by reducing harm caused in the delivery of care. And I think the goal here is to prevent harm that's caused by just either misinformation or not having information. Sometimes you just don't know what's going on with a person, and things happen for lack of information. And number 2 is to strengthen person and family engagement as partners in their care. 3 is to promote effective communication and coordination of care. And I think this is where electronic information is really critical, because it's a little more accessible, can be a little more accessible, a little more timely, and allows coordination between different providers in different areas of the patient's care. Number 4 is to promote effective prevention and treatment of chronic disease. That is a loaded statement if there ever was one. That's a lot in there. The 5th one is to work with communities to promote best practices of healthy living. And then finally, number 6 is to make care affordable. And, these are not easy. These are not easy things to do. And I think really the only way we ever get there is with more information, for you having more information to be able to make more informed decisions. And if you're going to be held accountable for something, then by all means, you should have the information available to be able to do that. To get to these quality, to this quality improvement information, the real key is to be able to collect the data up front that gets us there. It's really the heart of quality improvement, is initially getting that information and getting it timely. Your data can help you understand how your systems work together, not the technical systems, but your programs and the care systems. And through that, identifying potential areas for improvement, and to set measurable goals and monitor the effectiveness of any changes. It's critical to have the right information to be able to actually take some action, make decisions based on the information being provided, and then look back and say, well, did that really help or did it not? And I'll even take it a step further. You know, all this information that's being presented is what we think is the best information right now, but we value and require your input and feedback on that. If information is not being presented in a way that's actually actionable or something you can do something with it, we need to know that so that we can help you, you know, be able to take better action on the information that's being provided. And I think I've heard other physicians who presented in this segment say this, that even though we may not be all the way there yet, there's really no time like the present to start getting this data collection into your office workflow. I know it's not easy. It's extra work. There's more to do. But the sooner you can get this into a workflow, then the better you will be positioned when this is all we do. And it's all about, performance-based healthcare. You'll be set up to actually capitalize on that and be way ahead of everyone else who's not doing it yet. And it'll be part of your practice. It'll just be a lot easier. It'll be seamless, and you'll be ahead of the game. So we really, again, value your input. We're here to really help through this process and want to provide, valuable information for you and your practice. Thank you.
Thanks, Dr. Roach. Appreciate your input and feedback. So so we've talked a lot about it, and you've seen some early snapshots. So Winter Laws is our project director with DXC on the project, and Winter's going to share a little bit about some of the give you a feel for the application. Winter?
Thank you, Jeff. I appreciate it. The system has a login screen, very typical of most login screens, where we use the SSL to encrypt password and username. Once you are registered and approved, we send that information directly to you so you can start working in this system. As a registered provider, once you're logged into the CQMS, the dashboard will be displayed. The dashboard will display the measure statistics for the current year and quarter. You can see that on the screen. And the graph shows a comparison with the CQM data you have entered as a user with the state average. To see how well you are trending with a CQM, you'd click the CQM, and an awesome trend graph will be displayed. So if you'll see that on the next slide. And this is the trend graph, which shows you how your data is in comparison to the state average for that specific CQM. Next, you'll see another slide that shows the measure as an example of CMS 153 and the patient age from 16 to 20, as well as the CMS ID for chlamydia, patient age 21 through 24. And you'll see specifically how that stratum statistics measures up. Then you'll see two options. There are two options to enter CQM data. So when you're entering data, you can either do it manually, and you'll see that there on the second line, as well as we accept a QRDA Cat3 file. And you can work with us to determine the best way to get that into the system. Next slide. The manual entry will require a numerator, denominator, as well as sometimes an exclusion or exception, depending upon the CQM. It is very easy to enter that CQM data, and as Jeff said earlier, DXC is currently available to assist with manually entering that data. We have data entry clerks where if you would provide the information in a PDF or an Excel spreadsheet, then we would bring that information provided with your permission to put that information into the system. Again, we want to make this a very easy process for you. Next slide. Once you complete the entry of the data, the View CQM Data detail screen will display with a summary of the entered CQM data, as you can see right here. So it definitely gives you an opportunity to see the information that you've entered. If it's a numerator of 12, denominator 25, the exclusions as well as the exceptions. So you get the opportunity to verify and validate that particular information.
And that takes us to the next one.
So that is the system in itself. And thank you, Jeff. Back to you.
All right. Thank you, Winter. Well, folks, we're at the end of our time and at the end of our session. We do want to open it up for questions. So in just a moment, we're going to enable the unmute feature, which will let everyone ask any questions that you might have of the team. And we hope that you'll share any questions that you may have. We're excited about the project. We hope that you have some interest in participating with us. We'd love to have you involved. This is how you get involved. So if you're willing to participate, and here's what participation looks like. If you reach out to us through the email or call us there, we'll schedule time with you to answer any additional questions, talk about what participation looks like in detail. We'll schedule some time to do some training, and then we'll just start collecting the information from you quarterly on a schedule that you define, and it'll be pretty straightforward. You don't have to report all the CQMs. You could, frankly, just report one of them. You don't have to have 1,000 members. You could, frankly, just have one. So we're a small practice, large practice. We like the diversity of the participation, and hope that you will consider participating with us. Again, this is a great opportunity to influence the department as they consider this type of technology and this type of solution going forward. So we also reference upcoming webinars, and that's it. So let's open it up for questions before we run out of time, and see if anybody has any questions for us. You can also submit your questions in writing through the application, and I'll just pause here and see if there are any questions. So there is, so now you should be able to right-click and unmute yourself if you want to ask us a question again. Sometimes we have a little technical issue with this app, and so if you want to ask us a question through the type, submit questions to the queue. If for some reason you have a question that we can't get to today, you can use that same email address that was on the slide previously and email us directly with any questions, and we'll follow up with you. We're available to meet through conference call or to come visit your site if you'd prefer. Even folks way down in Brunswick. We prefer to go to Athens, Georgia, if we possibly can, but that may have a football reference associated with it. We're sort of unmuting lines individually, so heads up, just in case you are multitasking, we are unmuting all the lines.
That's muted.
Okay, so we've unmuted everybody we can. All right. Is there one more below there? Below Tiffany? Okay. Okay, folks, we really appreciate the opportunity to share information about our project. Again, we hope that you will consider participating. We think once you're up to speed on the application, you have your IDs, we think the input process on a quarterly basis could be as minimal as 5 to 15 minutes on a typical quarter. And so we would love the opportunity to talk more with you. Thanks again so much for participating, and I think we do have a brief survey that'll pop up at the end. Thanks, everyone.
Have a great day.